Known case of diabetes, having one eye NBE elsewhere, and vision is 6-9 with FR dull. Other eye has vitreous hemorrhage. Plan is PRP. Angle is narrow. Plan is YAG PI. In a case of pseudophakia, there is PCO formation. Plan is YAG capsulotomy.
इल्यूमिनेशन एंड ऑब्जर्वेशन आर्म शुड बी, जैसे हम स्ट्रेट लाइन में देखते हैं, एक लाइन में इल्यूमिनेशन और ऑब्जर्वेशन एक लाइन में होनी चाहिए. वर्टिकल स्ट्रेट लैम्प बीम with the illumination should be narrow and short to the minimize the back the scattering the straight lamp. Vertical straight lamp beam होता है वो illumination के should be एक ही एरिया में नैरो होने चाहिए, so that कि जो लेजर जाए वो प्रॉपर्ली जाए. मैग्निफिकेशन बिटवीन 5 times to 12 times हम इसको मैग्नीफाई करते हैं, एंड जो स्टार्ट करते हैं लेस मैग्निफिकेशन से करते हैं. हमेशा बड़ा मैग्निफिकेशन नहीं करेंगे. बड़ा मैग्निफिकेशन में क्या ड्रॉबैक होता है कि एरिया छोटा हो जाता है. आप किसी भी चीज को बड़ा करोगे एरिया छोटा हो जाएगा, तो आसपास की चीजें आपको नहीं दिखती है. जो जनरली यूज करते हैं जो लेंस, वो कौन सा होता है, एरिया सेंट्रलिस 84% वाला होता है. ठीक है. डायनेमिक, ये क्या करता है, डायनेमिक फील्ड ऑफ विजन होता है. जो मैग्निफिकेशन होती है 1.06% की होती है, एंड 0.94% प्लस लेजर स्पॉट ऑफ मैग्निफिकेशन फैक्टर. ये जो होती है एरिया सेंट्रलिस जनरली हम.
The commonest laser that we all use is the frequency doubled ND-YAG laser, which is a green laser with a wavelength of 532 nanometers. It can be delivered on the slit lamp using contact lenses or using the indirect laser ophthalmoscope with a 20 diopter lens. Or we can use endolaser during vitreoretinal surgery, but because it has a number of advantages like a wider field of view and better visualization in hazy media. The only downside to it is actually the toll that it can take on your spinal health, so you'll need to take care of that. Next, check that you've got the correct patient, the medical record number, go through the advice and see what kind of laser has been advised and for which eye. Next, don't forget to give the patient a little heads up about what the procedure entails and then take their consent. In case the patient has already had a previous session of laser, do check the fundus before starting laser, because some of them can have an exaggerated response to the previous session in the form of massive choroidal detachment, and in that case you might need to defer laser. Once all this is out of the way, we need to check the equipment. So ensure that all the cables are connected, provide protective glasses to everyone else who's in the room, and then set your parameters. Always start off with the lowest parameter settings and then titrate as and when needed. For example, when you move from the posterior to the anterior retina, you might need to decrease the power. When there's an area of media opacity, you might need to increase the power. So what are the standard parameters for the 4 main kinds of laser that we do? You can go through this table at your own convenience. What's important is that PRP and sectoral laser have similar parameters, and barrage as well. Focal and grid laser are of course done near the macula, so the parameters are always less in them. If you're using an indirect laser ophthalmoscope, the spot size is constant and ranges between 300 to 500 microns. The endpoint of laser is the intensity of burn that you want, and the burn intensity is dependent on 3 things. It's directly proportional to the duration of laser and the power of laser, and it's indirectly proportional to the spot size. So we'll be discussing the following types of lasers: panretinal, sectoral, focal.
Straight ahead. Very nice. Lights off.
As we know, it's commonly done in proliferative diabetic retinopathy, and it's done in 3 settings, in any order. So for one setting, you do the nasal retina, leaving a gap of around 1 disc diameter from the optic disc edge. For another setting, you can do the superior and the inferior retina together, but staying outside the vascular edges. And then another setting, you fill up the temporal retina, keeping a gap of 2 disc diameters from the foveal edge. Now each sitting involves around 600 to 800 burns, making it a total of 1800 to 2400 burns for a complete 3-session PRP. The burns need to go anteriorly at least till the equator, if not more. So now for some practical tips in PRP. Before starting laser, it's a good idea to note the macula first, just to orient yourself. In patients prone to vitreous hemorrhage, start off with the inferior retina, because if there's any hemorrhage, it's going to collect below and then preclude lasering the inferior half of retina. Horizontal meridians have the ciliary nerves, and so lasering in those areas may be painful. Better to reduce the power and do it towards the end of your laser. In areas with dense vitreous hemorrhage, you might need to increase the power. Another option is to use a red wavelength laser. Now, we also need to be careful to avoid lasering over certain areas. These include retinal hemorrhages, major retinal vessels, chorioretinal scars, the papillomacular bundle, NVD or NVE, and areas of traction. What is the indication for a fill-in PRP? We need to do a fill-in PRP when there is persistent or progressive neovascularization, even after having completed 3 settings of PRP. How do you know that? So you'll see that patients will have active tufts of neovessels and they will not have regressed. They might even get newer areas of neovascularization. There might be fresh vitreous hemorrhage. And of course, there might be areas where there's a lot of gap between the laser spots, that is skip areas. Laser marks may be deficient either anteriorly or posteriorly. When doing fill-in PRP, these are the areas that you need to pay attention to. So cover the skip areas, the areas having new NVEs. Posteriorly, you go as close to the arcades as possible, and anteriorly between the equator and up to the aura. If it's extensive, then it can be done in 2 settings. Pectoral laser is nothing but scatter laser in one quadrant of the retina. Its parameters are the same as PRP. It's done in conditions that have localized neovessels, for example, retinal vein occlusion, retinopathy of prematurity, vasculitis, and radiation retinopathy. Ideally, it should be done under FFA guidance. So this is a patient with retinal vein occlusion. Fundus fluorescein angiography shows us the areas of neovessels and the capillary non-perfusion areas, and that helps us in placing the laser marks. Now we move on to the macular lasers. As per the ETDRS protocol, direct or focal laser and grid laser both result in a 50% reduction in the risk of moderate visual loss in diabetics. Of course, they have their disadvantages because they lie so close to the fovea. So any kind of expansion in the laser scars would encroach on fixation, resulting in central vision loss. Direct laser is what we commonly refer to as focal laser. The main indication is focal macular edema in diabetics, where the leak is from a single or a group of microaneurysms. Another indication is, of course, focal leaks that are away from the fovea in central serous chorioretinopathy. Now, the goal of focal laser is to directly treat the leaks. So we treat all the lesions that lie within 2 disc diameters of the macular center, ensuring that we stay at least 500 microns away from the fovea. In patients where the vision is lower than 20/40 and there's persistent edema, we can go up to 300 microns from the center. Grid laser is done in diffuse type of diabetic macular edema, where the leakage is from dilated capillaries and not microaneurysms. The pattern of laser is C-shaped, going up to 3000 to 3500 microns away from the center of the macula. Of course, no burns are placed as usual within 500 microns of the disc or the fovea. Now, whether we do a focal laser or a grid laser, in any kind of macular laser, it's important to localize the fovea first. If there are clumps of microaneurysms, either you can use multiple 50 micron hits, or you can also use a larger spot size. Any treatment over the papillomacular bundle should be very minimal and non-confluent. We should also avoid lasering over areas with nerve fiber layer, that is flame-shaped hemorrhages. Modified grid laser is a combination of the previous two lasers. It involves direct laser to all the leaks and grid laser to the areas with diffuse leaks. Its main difference from the ETDRS protocol is that modified grid laser involves burns of a lower intensity, that is less power, and smaller size. Lastly, we come to barrage laser. Barrage laser is the creation of a barrier around a peripheral retinal degeneration to limit or prevent the accumulation of subretinal fluid. The common indications are lattice degeneration, horseshoe tear, retinal dialysis, and retinal holes. Laser marks are placed in 2 to 3 rows around the lesion, half a burn width apart. So do we need to laser all lattices? The answer is no. You only need to laser those which have tractional holes or breaks, symptomatic lattices, patients with a history of retinal detachment in the other eye, patients scheduled to undergo refractive procedures or even cataract surgery, lattices with subretinal fluid around them, one-eye patients, family history of retinal detachment in the patient, and atypical lattices like radial lattices which are seen in Stickler syndrome. Asymptomatic lattices, even those with atrophic holes, can just be observed. In a challenging scenario, we have a patient here with multiple large lattices. Do we enclose all of them together like this? No, this is not advisable because if there is a gap in the laser marks, all 3 lattices would be at risk. Instead, try to enclose each lesion separately. Here we have another challenging scenario where a patient has multiple rows of lattices. In such a case, always start with the anterior-most row first. Use scleral indentation and try to laser the anterior margin of the lattice first. If that's not possible, laser it posteriorly and extend anteriorly till the ora. Proceed with the remaining rows from anterior to posterior and try to enclose the lesions separately as much as possible. Practical tips for barrage laser. Now we already know that it's very important to laser the anterior margin of lesions because that is where the vitreous adhesion is the strongest. The most common cause of retinal detachment in a barrage laser is because of insufficient treatment of the anterior margin. For example, in this picture, we can see that there is deficient laser anteriorly. So this should either have been enclosed completely or at least it should have been extended to the ora. In some patients, for example patients with Stickler syndrome who are prone to developing retinal detachment, some authors have suggested doing an ora secunda cerclage where prophylactic laser is done 360 degrees, essentially creating a second ora. Patients who develop a fresh lattice near a previously existing lesion, the laser marks can just be extended to the previous old laser marks. Coming to some more special situations, in children and patients in pediatric age group who may not cooperate for barrage laser, it can be done under general anesthesia. Sometimes for very anterior lesions, it may be difficult in pseudophakic patients because of the PCIOL edge effect. In these patients, cryo is another option to be considered. Patients who have dense media opacity due to cataract, the laser can be done after doing cataract surgery. In patients with proliferative diabetic retinopathy as well as diabetic macular edema, we do 2 sittings of PRP and then do a macular laser, and then 1 month later we finish the 3rd sitting of PRP. Lastly, after finishing laser, don't forget to advise, explain, and prescribe. So advise good systemic control and tell them not to exert or lift heavy weights. Emphasize on regular follow-ups. Explain to the patients that the effects of laser may take a couple of months at least to be seen. Prescribe topical corticosteroids or NSAID drops.
Cases of primary angle closure suspects, primary angle closure and primary angle closure glaucoma cases. Here we can see a closed angle. This is again a closed angle. Laser peripheral iridotomy. This is the Nd:YAG laser console. And here we can see the parameters. The Abraham iridotomy lens is used to perform PI. Use of this contact lens makes the procedure easier. The laser energy is concentrated at the level of iris, number of corneal epithelial burns are minimized, and lens keeps the eye open. This lens is actually a plus 66 diopter plano-convex button bonded into a decentered 8 mm hole. Here we can see the Abraham iridotomy lens. After taking informed consent of the patient under topical anesthesia with proparacaine 0.5%, iridotomy lens is applied. Patient is asked to look straight. Iridotomy is performed in peripheral 1/3 of the iris just anterior to arcus. The site which is selected is preferably the crypt of the iris, and the power used is 4 to 8 millijoule depending upon the thickness of the iris. Here we can see the magnified view of the crypt, and here the laser energy is being applied. The laser shot is given, and we can see the iridotomy opening. Another shot. Sometimes even the single shot is enough to perform the iridotomy. Sometimes the patient might require 2 to 3 shots, but multiple shots are to be avoided. Here is the magnified view of the iridotomy. After the procedure, after 1 hour, intraocular pressure is checked, then topical steroid is applied for a period of 1 week, and at 1 week, again intraocular pressure is checked, and the patency of peripheral iridotomy is confirmed. Thus,
PCO YAG laser has this joystick dial for adjustment of energy in millijoules. For routine cases, 1 to 3 millijoule energy is enough. And here the yellow is a standby and red is the ready mode. Laser uses a quick pulsed ND-YAG lasers to apply a series of focal ablation in a circular fashion in the posterior capsule and create a small circular opening in the visual axis. When PCO becomes thick enough that it causes sufficient decrease of vision, glare and interference with daily activities, and the time to cataract surgery is past more than 6 months, then we do ND-YAG laser capsulotomy. In high myopes, there are chances of retinal detachment post-YAG capsulotomy, so do 360-degree retinal organ barrage before YAG capsulotomy. It can be done with and without Abraham YAG capsulotomy lens. First of all, dilate the patient and put a drop of topical anesthetic. Focus the red helium neon laser slightly posterior to the lens to avoid lens pitting. PMMA lenses are more resilient to pitting than acrylic lenses. I do circular pattern starting at 9 o'clock. You can see here, and going clockwise. You can clearly see the gush of fluid when the YAG laser smashes the posterior capsule. I am thankful to Dr. Ibrahim who helped me while making this video. Now slowly I am going towards 12 o'clock. You can also make cross pattern, but always start at the periphery, adjust power. In thick PCO, high energy is required, but here the PCO is not thick enough, so we are using 2 millijoules energy in this patient. Now you can see I am doing 3 millimeter small capsulotomy. It is as effective as large 5 millimeter capsulotomies. I am going in a circular fashion. You can see that's how ND-YAG laser capsulotomy is done. Make sure you don't pit the intraocular lens because the pitting is permanent and the patient will not be able to see clearly. So that's how you perform ND-YAG laser capsulotomy. Post-op topical steroids, NSAIDs and anti-glaucoma are given for 10 to 12 days. Thank you very much.
Hello, I'm Dr. Walid, and I'd like to explain the parameters of the YAG laser that is used mainly for posterior capsulotomy. Actually, start with ready and adjust the power. The power, you can start from 2 millijoule energy to up to 4. Actually, from my experience, I prefer 4. That gives good results. This is the pulse burst. Posterior capsulotomy needs 1. Okay, you can do 2 or 3 if you do peripheral iridotomy. Here, the counter of the shots will count the number of shots that you did. Okay? Here is the most important. This is the YAG focus shift by micrometer. Okay? Here is the posterior. Posterior by 500 micrometer is the best distance for the posterior capsulotomy. You can use other distances, but the best is 500. If you have membrane or something in front of the lens, you can use the anterior focus, or either plano, which is 0. And you can use contact lens, the Abraham contact lens. If you use the Abraham contact lens, you should use low power. Thank you very much.